Good morning, everyone. Welcome to Grand Rounds. Just a brief announcement at the end of Grand Rounds. We're going to end the presentation just a few minutes early to allow for an awards presentation for a couple residents. So don't bolt out the door right away after the presentation. But it's my pleasure today to introduce Dr. Ben Anderson, who's crossing the divide and joining us from the Department of Surgery for a lecture today. Just a little bit of background. He's originally from California and received his undergraduate degree from Pomona College. This was followed by medical school training at Einstein in New York, and then general surgery residency at the University of Colorado. He also completed a fellowship in surgical oncology at Sloan Kettering and Cornell Medical College. He then returned out west and joined the faculty at the University of Washington, worked his way up to a professor in surgery in 2004, and also holds a joint professorship in the Department of Global Health and Medicine. He is the director of the Breast Health Clinic at the SCCA and the chair and director of the Breast Health Global Initiative that's co-sponsored by the Fred Hutch as well as the Susan G. Komen Foundation. He has earned numerous awards and positions of national and international recognition. Just a few of the highlights. He served as president of the American Society of Breast Disease. He contributed to the 2005 World Health Organization Cancer Prevention and Control Resolution. He earned the 2011 Partners in Progress Award from the American Society of Clinical Oncology, and that's just the beginning. He's an editorial board member for numerous journals, including the Annals of Surgical Oncology. He has nearly 150 peer-reviewed publications, nearly 50 book chapters, numerous editorials and invited commentary, and speaks all over the world about his interests. His research is broad and well-funded, from oncoplastic surgical techniques for breast conservation therapy to international breast health care with a focus on low and middle income countries. We're delighted to have him here today to speak to us about breast cancer and global health, spanning the capacity gap. Please help me welcome Dr. Anderson.
Thank you, John. That was a really kind introduction. It's really actually quite an honor to be able to speak to you today. I guess I'd like to begin by saying it's really all about collaboration. Everything that we're going to be talking about in global healthcare has to do with how do you put the pieces together. And it being here at the University of Washington has created these opportunities that I just feel incredibly fortunate about. The Breast Health Global Initiative is a project we started back in 2002, which was how do you address breast health care in low and middle income countries. And what I'll be talking about at the end is a new initiative that we're beginning. I co-chair this with Dr. Julie Grelo from your department, and it's called Breast Cancer Initiative 2.5, the goal of which is to improve outcome for 2.5 million women between now and 2025 in alignment with WHO goals. What I'd like to do is show you how does breast cancer look in the United States, what is our framework, and then transition into the global picture, because there are differences, which probably have much more to do with our healthcare systems than they do with the biology of the disease. We'll talk about adapting to existing resources, because that's the fundamental concept that drove BHGI. We'll talk about early detection and diagnosis, which is fundamental to improving outcome. And then we'll move into BCI 2.5. How do we target outcomes to improve where we stand? So as you know, breast cancer is the most common cancer among women in the United States. About 230,000 cases are diagnosed each year. It's actually not the leading cause of cancer-related death. Lung cancer is. And so these have been in transition, and this actually has a lot to do with smoking and smoking behavior that puts lung at the top. But if you look at the demographics, isn't it interesting to see how breast cancer is head and shoulders above all of the other cancers among women? Why is that? What is it about the biology of the disease that so predisposes women to this process? I think it's really important to consider that. It has to do with female physiology and biology, and that's the fundamentals of everything that we're going to do. There was a major rise in breast cancer incidence between 1982 and 1990. It leveled out until just before 2000, and then it started to drop again, and again it has leveled out. So what is this? What's happened in these periods that have made these changes that we've seen? Mammography has made a major impact on this. This is what is considered the cause of that major rise in incidence between 1982 and 1990, because it was the trials, the HIP trials in New York that showed that screening mammography improves breast cancer mortality, and the subsequent rise in its use in this country that led to that increase. And it's very specifically the ability to diagnose cancers before they're clinically apparent. In particular, microcalcifications. We can see these microcalcifications on a mammogram, and that helps us diagnose DCIS. Ductal carcinoma in situ is not life-threatening in and of itself, but it's a precursor to invasive cancers, and this is why we treat it. It's very interesting to see how the stage-related changes occurred over that period of time. So when we started doing screening mammography, we specifically saw a rise in DCIS and node-negative cancers, while we saw a flat line of node-positive cancers. It was typically assumed that when we would start the screening, you would get more early stage and therefore less late stage. That actually did not transpire. And this also, I think, has something to do with the biology of the disease and is part of related to the controversies that we're addressing globally. Now, that drop that happened in 99 to 2004, this has commonly been attributed to the use of hormone replacement therapy or the decreased use, in particular in response to the Women's Health Initiative. Here is an example of the study that supports this. This was in a mammographically screened population. And when this came out in JAMA, what they said was, oh, well, we're going to see a major change. I'm sorry. This study is the Women's Health Initiative, and what it showed was that when we used combination hormone replacement therapy in a prospective randomized trial, there was an increased rate of breast cancer incidence. The reason the trial was started was it was thought that the hormones would decrease the incidence of cardiovascular disease, since fewer women have heart attacks than men. That actually did not happen. That turned out not to be the outcome, and so they stopped the trial as a result of this increased rate of breast cancer, which actually was already predicted. So people said, oh, well, you know, that publication in 2003, that was the reason that we saw this major change in outcomes. So, what I'm illustrating in this slide here is that in 2003, that's when the Women's Health Initiative publication was published, and everyone said, oh, women are using fewer hormones than they were back then. What you notice is it didn't continue afterwards. I am really doubtful that the hormone replacement therapy alone is responsible for this change. I think it's multifactorial and something we need to continue to evaluate. So when I was a surgical resident, the teaching was we're finding more cancers, but breast mortality is flat. Therefore, we're doing better. And that obviously, there's a logical question about, is that really right? If we have flat mortality but increasing incidence, maybe we're just finding a bunch of cancers we didn't need to know about. This changed in 1990, and what we started to see at that period was a drop in breast cancer mortality by between 1% and 2% per year. And that has actually continued until the present time. Since 1990, overall breast cancer age-adjusted mortality has dropped by 34%. So we're clearly doing something right. And it is interesting to note that this drop started about 8 years after we started doing this screening. And that, of course, is what you'd expect when the median survival of untreated breast cancer is between 3 and 5 years. So you would expect that there would be a delay before you started to see an increasing, a changing outcome based on this. So when people get nihilistic about screening mammography, I think you have great difficulty explaining this population-based demographic to say, oh, it's really unrelated to mammographic screening. There's been a lot of modeling work that's been done in this area. CISNET is a group that has tried to address this. And what they have identified is it's really early detection is essential to improving outcome. But it really is not the early detection that saves lives. It's the early treatment that saves lives. Finding the cancer doesn't help you. You have to do the right thing. And it actually, the evidence is very clear that it's the combination of adjuvant therapy and early detection that has led to this decrease that we've seen. I would love to tell you that surgery fixes everything, since that's what I do for a living, but the fact is it's what you do for a living that has made this impact. So whatever it is we do with breast cancer, you have to link it to appropriate multimodality therapy. And you can see the modeling picture that we've seen, really, it's the combination of the two. We sometimes get into arguments between the medical oncology community and the radiology community. It's early detection, it's treatment. I think that's like arguing about, did you like your left hand or your right hand better? I think you really need both in order to improve on outcome. So how does this vary from the global picture? Because there really are fundamental differences. Actually, breast cancer is the most common cancer among women around the globe. There are countries where cervical rivals it. There is no cancer that is ever head and shoulders above breast. Of the 19.7 million cases that are predicted to occur in the next decade, it is actually the majority, 10.6 million, that are projected to occur in low and middle income countries. By 2020, according to GlobalCan statistics, over 1 million cases per year are going to be diagnosed in low and middle income countries alone. So this idea that, breast cancer is really just a high-income country problem and we don't really have to think about it, that's really a flawed concept. We can either wait till it's a bigger, more disastrous problem, or we need to start preparing now. And actually, breast cancer is the most likely reason that a woman will die from cancer around the world. Of the 5.8 million cases that are predicted to occur by GlobalCan, the majority, 3.9 million, are projected to occur in less developed countries. And if we use WHO's definition of premature and preventable, meaning under the age of 70 and a disease that we do have effective strategies for improving outcome, this is at least 1.5 million lives that are going to be lost in the next 10 years. So there really are things that we need to think about, and this has been the basis of the work that we've done. So if you look at the map, what we're seeing here, there's incidence and mortality. This is the incidence graph. The darker colors are higher incidence. So you can see in the high-income countries where screening is prevalent, we have a much higher incidence. By contrast, when you look at mortality, the map reverses. So here's incidence, here's mortality. It is the low-income countries where the incidence is low, but where the mortality rates are very high. In sub-Saharan Africa, 70% of people will die of their disease. Well, here the ratio is about 1 in 5. So there clearly are opportunities for improving on outcome. How is this that we're going to translate what we already know works into settings that do not? Now, if we look at these incidence rates, globally breast cancer is rising everywhere. And what you can see in the high-income countries like ours, Australia, France, and Spain, they did this rise, and then they started to drop in 2000. Now, the hormone replacement therapy argument really has to do with the U.S., so it doesn't relate to all of these other countries. Again, there's something happening that changed that, and we have to evaluate what it is. If we look at middle-income countries, Latin America is dominated by middle-income countries such as Costa Rica and Colombia. They've also had this rise, and we also see rises in low-income countries. Now, the mortality, we've seen this drop. Here's that 34% drop that has been mirrored not just here in Canada, but Australia and New Zealand, whereas in the middle-income countries, mortality is flat. They have not yet seen the drop that is already manifested here. Again, there's clearly an opportunity for improvement. If you go to the low-income countries like sub-Saharan Africa, people are living longer. They're doing better with infectious diseases, so actually mortality of breast cancer is continuing to rise in those lowest income environments. Some have argued, well, in the high-income countries, they've got this treatment, and it's really the treatment. It's not really the early detection or anything else. But isn't it interesting to look and note that in Singapore, Japan, and Korea, which are all high-income countries, they have not seen that drop in breast cancer mortality, at least not yet. What's different? They do have the treatment. They are using it. Could it be biological? Yeah, it could be biological. They have actually not started screening. There are arguments about whether screening mammography works as effectively in women of Asian descent than it does of women of Caucasian or African descent. But nonetheless, the point is it's not just about the money. There's more to this picture than that. Again, opportunities. But when we started doing our work in low and middle income countries, one of the points that was raised to us was, some countries are so poor that breast cancer is just not a significant problem for them, which of course begs the question, at what point are resources so limited and competing demands so great that it makes no sense to talk about breast cancer? In 2004, we went to Ghana, West Africa, to try to answer that question. Ghana is a country of now more than 20 million. It is actually an economic success story. It has moved from being a low income to a lower middle income country. Life expectancy is now rising, is probably above 60 at this time. Literacy rates are high. There's much going on that's successful in Ghana, and now they have oil, which is also an improvement. This is the Komfe Noche Teaching Hospital in Kumasi, which is the second largest city. It is a 10,000-bed hospital. They have a medical school, a nursing school, a dental school, and this is their breast clinic. And you can see the women lined up outside. You show up first thing in the morning, and you stay until you're seen, which might be 3 o'clock unless you're not seen and the doctors go away, at which point you're supposed to come back the next day. When I went into the clinic, this was the earliest cancer that I saw. You can see that closer to me in her left breast, the breast is somewhat asymmetric and it's pulled in, and here is the diagram that the surgeon drew of the 10-centimeter mass that was palpable in her breast. So we would not consider this an early cancer. What was much more commonly seen was cancers like this. This is an ulcerated tumor. The best we can do with this is palliative care. She's coming in for repeated wound visits. It's a terrible quality of life issue. We do occasionally see these here, but it is certainly something that is uncommon. There are competing healthcare systems. So just as we also have competing healthcare systems, this is a billboard driving down the street, and what they're advertising is a traditional medicine clinic, an herbal clinic, and you can see the picture of the woman with her asymmetric breast, and it says at the top, "We treat breast cancer." And this is typically where women will go first. And it is later that they would come to the hospital when the techniques here have not been effective. When you ask women, why would you do this, the answers are, well, why would you want to come in early for a cancer diagnosis? Cancer is invariably fatal, so that's just bad news. Why would I do that? And it's odd, there were a number of misconceptions, that you did something wrong to create this. Witchcraft is often thought that somebody hexed me and now I've got this issue or this problem, and so that's really, it's about something else. None of the risk factors here that are identified are actually associated with it. And they'd say, why do you go to the hospital? They're just going to cut off your breast and you'll be dead in 2 years. Now, here's the problem. The healthcare system was making this true because at that time, they had no insurance plan. The way it worked was you would come in, the surgeon would say, yeah, you need a mastectomy, and then they go away and they collect money from their family and their home. And then they come back and then they get the mastectomy. The surgeon doesn't necessarily connect them to the medical oncologist. Radiation is available in this country, but that wasn't necessarily done. But you would still have to pay as you go. In fact, when we were there at that time, they would hand the mastectomy specimen to the patient's family and say, take it over there to the pathology lab because you'll want to have it analyzed, and of course they're going to charge you again. It's not hard to imagine why that mastectomy specimen wouldn't make it there. But if you take a locally advanced cancer and only operate on it, we know, based upon the biology of breast cancer, you're not going to improve on outcome because it's the drug therapy that affects the micrometastatic disease. So actually, you're going to be dead in 2 years? Absolutely right. Fundamental flaw in the system that had to be addressed in order to begin to see improvements. And sometimes the surgeries don't work very well. This is an example of someone who had a mastectomy and now has an axillary node failure. You can see the disease growing back in her axilla. Terrible quality of life issue that she lived with until she died of this horrible disease. We need to do things about this. So when you say, well, what are the obstacles? Well, advanced stage at diagnosis is a problem. Mastectomy without adjuvant therapy, not having an intact system that's functional. When we went to they did have a multidisciplinary clinic. There was one pathologist for that 1,000-bed hospital. One pathologist for a 1,000-bed hospital. And that meant that pathology reports typically took 4 to 6 months to generate. So we realized, well, now there's an example of you have to fix that problem. If you can't prove it's cancer within 4 to 6 months, how could you impact on it therapeutically? So it's identifying gaps. That was part of the basis of our work. It's how do we adapt to existing resources in realistic ways. Ideally, you would prevent cancers. That would be the best. And this is why tobacco control is the low-hanging fruit of cancer control globally. But if you can't do this, then you need to go through this sequence of early detection, diagnosis, and treatment. You have to find it early, you have to prove it's cancer in a reasonable period of time, and you have to provide appropriate multimodality therapy. The way we approach different cancers is different because the biology is different. So if we have the infection-associated cancers, like cervical cancer associated with with HPV infections, or hepatitis leading to liver cancer, these are areas where vaccination and primary prevention strategies are really very cost-effective and logical. Similarly, tobacco control, obesity control, diet, alcohol. These are the right approaches for these diseases. Now, but if you look at breast cancer does not have a tobacco analog. There is no single powerful risk factor associated with the development of this disease. There are a series of, with the exception of BRCA1 and BRCA2 gene mutations, which is only responsible for maybe 10% of the breast cancers that we diagnose, it is these series of low-level risk factors. So we can try to address it, prolonging lactation, going to a year for every child. That actually is predictable to save lives. Physical activity, weight control, alcohol control, avoiding exogenous hormones, avoiding radiation. Actually, most of those risk factors are problems that we have, not problems that are in low and middle income countries. But even if you take all of these together and ask how many of breast cancer lives would we save with this, this would be responsible for maybe 20%. The most could be 30%, and that assumes that you could get everybody to do all those things that you're supposed to do. So you would still be missing the majority of breast cancers. And that's why we have to think in the context of healthcare systems. What's the system that will make that early detection, diagnosis, and treatment by stage? How are we going to make that functional and work? That was the basis of the Breast Health Global Initiative. So what we did was we modeled ourselves after the National Comprehensive Cancer Network, NCCN. We pulled together panels, but these were international experts. And we held a series of global summits. The goal of the meeting wasn't the meeting. The goal of the meeting is what we published from that meeting. And what we created were comprehensive guidelines that were then published in peer-reviewed literature. The first two summits focused on the nature of the disparities and this development of resource stratification, which we'll talk about in a minute. The next two summits validated what we found in those resource stratified guidelines. And the last summit that we held, and I think this probably will be the last summit for the Breast Health Global Initiative, we focused on supportive care and quality of life. What do you need to get through the treatment, or what do you need at end of life to make this a comprehensive functional system? This idea of resource stratification, I think, is the most valuable concept that came out of this work. We recognize that if you look at all of the resources that are available, some come before others. You have to prioritize them. When you look at American or European guidelines, including the NCCN guidelines, they give you no prioritization. So they lump everything together. There are some resources that are fundamental and basic and you cannot do without. Breast surgery is an example. If you cannot remove the primary tumor, the best you could hope for is palliative care. Limited level resources would be most of the drug therapies that we talk about. Prospective randomized evidence shows us decreases in breast cancer mortality. And so clearly those are very high priority in what it is that we do. Enhanced level resources we defined as those that might not necessarily improve survival, but would improve outcome or options. So for example, doing breast conservation surgery, that means doing a lumpectomy followed by radiation. Women don't live longer if you do that instead of mastectomy, but it makes the therapy more acceptable. And so you may well get better participation. And then there's some resources you should not talk about. There's some resources that really are excessive and they don't provide adequate benefit. And unfortunately, these are the things we tend to talk the most about in our meetings. So PET scans, breast MRI, boy, we talk about this all the time. We know that imaging the breast better cannot improve on outcome because you don't do better removing the whole breast than you do removing a part of the breast. PET imaging is great for seeing metastatic disease, but that's not going to impact on outcome. So there are actually things you should discourage. These tables are the basis of what we did. So those 4 levels, these are all standard resources that are available: healthcare systems, early detection, diagnosis, treatment by stage, laid out in priority. And actually every drug that's on there is already on the WHO essential medicines list. We did a survey to analyze, is this work being recognized? Is anybody using it? Because if you create it and nobody thinks it's helpful, well, then it didn't matter. So this was an MPH thesis where what our worker did was she surveyed the literature, both peer review and the gray literature, and identified 776 articles that cited the Breast Health Global Initiative core publications. And what was really exciting to see, the red publications are ours. So that's, we're building our system, that's referencing prior work. The purple is external resources. So we could see that it was being taken up more and more on the outside. And when we asked, where are these authors from, 60% are from low and middle income countries. So we thought this is evidence that, yeah, this concept is working. Now, if you then asked how many of those publications had to do with an actual implementation as opposed to a theoretical one, very few. It was about 5 or 7%. And so that told us, okay, the implementation step is really important. Here's an example of why looking and identifying what you don't do is important. We were invited to do a situation analysis in Vietnam in 2011. This is in Hanoi. We're walking into the K Hospital, which is the cancer hospital in the north part of the area. These are two pictures. On the left, they had a department of breast surgery. I thought that was really impressive. And on the right is walking down the hall, looking into a patient room. And what you can see in that patient room are 4 beds per room and 2 or 3 patients per bed. And that is standard. And no one really thought much about that because that's standard. This is what it's done. But what they really wanted us to see was their brand new molecular pathology lab. And we asked, what are you going to do with a molecular pathology lab? No one was really quite sure what the answer to that was, but they had one. And I'm not criticizing the Vietnamese. We actually set this up because this is what we're the ones talking about molecular pathology as opposed to how do we do healthcare delivery better. So actually, I think the onus is on us to help create these prioritizations. NCCN has now taken up the resource stratification approach. The cervical cancer guidelines have now been published, and the plan is between now and the end of this year to publish resource stratified guidelines based upon their standard algorithms for 7 of the major cancers that are common. So here's the standard algorithm for cervical cancer treatment, one of those pages. The enhanced level, you can see where they're graying out the parts that you wouldn't necessarily need to do. So you can see what it is, but you can identify this is what you don't prioritize. Here is the limited level. We're taking out more and more. We're narrowing it down to the core elements. And when we get to the basic level, actually they are introducing, we defined in this, basic level meaning you don't have radiotherapy, which is actually the standard in most of sub-Saharan Africa. Radiotherapy, we really don't have enough radiotherapy around the globe. But the alternative would be doing a hysterectomy after neoadjuvant chemotherapy. It's not what we do here, but it's a very reasonable substitute and definitely better than doing nothing. And so using this type of system, I think we're going to see more of this. I'm very pleased to report that WHO is now doing work using the resource stratified framework and has identified BHGI as a framework for doing this. So now let's talk a little bit about early detection and diagnosis. If you look at the demographics of breast cancer by stage, in our part of the world, 90% of cancers are diagnosed as DCIS, stage 1 or stage 2 cancers. This is because we screen. This is because patients are aware. They come in. They participate. By contrast, in India, 3/4 of cancers are presenting as locally advanced stage 3 or metastatic disease. And we know that that disease is hard to treat with all of the resources that are available, let alone resource constraints that make that difficult. So what this illustrates is downstaging disease in and of itself is an essential step. Whether that just downstaging, is that going to improve mortality by itself? Maybe, maybe not. But it's necessary. You can't get there from here with that distribution that we see in India. There's a lot of debate, as everyone in this room is already familiar with, about screening mammography. And there's a spectrum. You know, there's politics and everything, and I think science, there's politics too. But this is this study was the U.S. Preventative Services Task Force analysis, which shows that on average there is an improvement in breast cancer mortality when we use screening mammography. And while the argument goes back and forth, the IARC, the International Agency of Research on Cancer, which is the research arm of WHO for cancer, they pulled together a group in 2004. This was a broad spectrum group, 76 experts from around the world. And the conclusion was the evidence is clearly there that for screening in age 50 to 74, we decreased breast cancer mortality by about 23%. The evidence, as we get younger, the evidence becomes more limited because there are fewer cancers to find and there's fewer data to support this. But the American Cancer Society, in their most recent version, they decided, okay, we're going to start at 45 and we're going to go every year. I think we've done a fabulous job of confusing the public about what it is that we're supposed to do in early detection. And I do think the bottom line is screening is a value. We need to come up with a better way of explaining it, and so that our primary care colleagues can know what it is that they're supposed to say. I really don't think we've done well. But they did look and say, well, mammographic screening can be cost-effective when you have high incidence disease, and it may be cost-effective in low and middle-income countries. But when WHO looked at the mammography question back in 2010, they said, yep, we think mammography is good, probably averts 19%, but it's impractical. You can't afford it. The feasibility of treatment, they were very nihilistic about its use. So we have to think beyond the mammography debate into where do we go. This is a study that our group, the BHGI, collaborated on in Indonesia. The question was, what happens when you go to an unscreened population and then you bring in mammography and clinical breast examination? So in this study, women, nurse midwives, and volunteers were trained in clinical breast exam skills. They developed a data collection process. They then screened women with both CBE and mammography and determined what were the outcomes. There were 1,179 women that had had both mammogram and clinical exam, and about a quarter of them had some finding that needed a workup. This is a point that is commonly overlooked. We fast forward from screening mammography to treatment, and we forget that there's a bunch of women that are going to have benign findings, but you have to work it up. So having an appropriate diagnostic facility is critical. Overall, 14 cancers were found. This is about what you would anticipate if you were doing a screening mammography trial. So that 14 is about right out of 1,000. Of the 14 cancers, 13 could be appreciated on clinical exam. Mammography only added 1 cancer. Now, this is not to impugn mammography. It's the point that in an unscreened population, you begin by finding the prevalent cancers. It's when you use it over time. So the point of this is you don't begin with screening mammography when you're in an unscreened population. And I think that this is a valuable finding. But there were some unexpected findings. Of those 14 women, 8 never were treated. And when we asked why were they not treated, 2 were refused, but 6 were lost to follow-up. What we didn't appreciate when we started this is they didn't have a longitudinal data collection system. So it really depends on the patient coming back and identifying herself. So recognizing medical record systems that follow out and you see people in repeated incidents, this is critical to making a system function. We don't think about it because it's inherent in what we do. And yet, if you're in a low-income country, they're usually doing episodes. You were hit by a car. We either fix you or you don't fix you, but then you go off again. Now they're talking about non-communicable diseases like diabetes and heart disease. It's going to require this framework, and you have to make sure it's present. What we know about clinical exam, actually in unscreened populations, it'll find about 60% of cancers, and actually there are times, particularly with dense mammograms, that we find it on clinical evaluation and the mammogram doesn't show it. We can argue about whether CBE saves lives. I would say it's essential. You can't do breast surgery if no one can do a breast exam. So we don't have a randomized trial showing the value of a scalpel. So that it's an essential element, and therefore it should be brought in, and we can then subsequently ask these questions. The Canadian trial has been used as evidence that, that mammography doesn't work. This was the most recent citation where the 25-year follow-up from the Canadian trial said, look, there's no difference between the mammographically screened women and the not mammographically screened women. And in our breast community, oh my gosh, everybody gets all upset, and they say, those Canadians, they obviously don't know how to do a mammogram. It must be that. But actually, it's really interesting. When you look at their control arm, the control arm, the median tumor size was right about 2 centimeters. Well, we would be very pleased to have 2-centimeter average tumors. When we were starting our breast trials in the 70s, median tumor size was 3 centimeters. So to me, the interesting question about the Canadian trial isn't how did they screw up their mammograms? It's what were you doing in the control group, because that's what we want to mirror. They are effectively getting early detection through other strategies. But we are asking the question, are we going to improve outcome with clinical breast examination? There are randomized trials that are in process in India, 2 major trials. And they're doing this both for cervical cancer, where they're doing direct visualization of the cervix, and they're using clinical breast examination. And it's really interesting how the data is panning out. We're not far enough out to know mortality differences. But what you can see on this graph is that you're seeing an increase in the early stage cancers among the women who have clinical exam. But there is not a difference in the advanced stage. They're not decreasing. The 2 are the same. This is the same thing we saw when we did mammography in the 1980s. So it may be that instead of just saying, well, all of the cancers are the same, maybe there's a subgroup that benefits from that early detection through mammography, and then there are others that are just bad biology cancers, and the treatment is what we're going to need, and they're going to keep presenting as this advanced stage disease. I think our modeling is going to need to have to start thinking this through in a better way. Self-exam is often criticized, and it's based upon a trial that was headed here at the Hutch by David Thomas. This was the randomized trial of self-exam in Shanghai. And they either trained women in self-exam, or they just let them find the cancers on their own and had like a placebo video on low back pain. What they saw was no differences in outcome, but there were more biopsies. And this got shortened to the 8-second soundbite, self-exam doesn't work. Well, actually, when you look at the control group, the Shanghai women, 40% of them were less than 2 centimeters in size. So actually, the Chinese women were really good at finding the tumors when they were small. This is completely different from what we see in India or sub-Saharan Africa. In retrospect, Shanghai wasn't the place to do this study. But again, it speaks to how do we get by whatever mechanism, how do we find the tumors when they are earlier? Latin America is dominated by middle-income countries, and this is a place where the whole screening debate is really panning out. With our approach in that resource stratification, you begin with taking history and doing an exam, pretty fundamental. You bring in imaging. Ultrasound is actually the first tool you bring in because you can add to your clinical exam and identify what looks like a cancer and what looks like a fibroadenoma, what needs needle sampling. We can segregate patients and improve our specificity. This mammography question is really prominent because some of the countries can't afford to do this. In Peru, this is a joint project that our group is participating with PATH, and what they're doing is they're looking at the question from a different standpoint. An error that I think we commonly make is that we make this assumption that everybody lives next door to the cancer center. And then we ask these purified questions about well, what does mammography do? What does clinical exam do? What do our drugs do? In implementation science, you look at it very differently. You take all the dirty data that you would have thrown out for your randomized trial, you throw it in, and you see, well, what really happens in an intervention? And while our randomized trials, the way we typically do them, have internal validity, in implementation science, we get external validity. What happens in the real world? So what are they doing? They're training in clinical exam in the health centers. They're going to the local hospital where they're doing a fine needle aspiration, and then they're using those results to decide who to send to the cancer center, which is 3 hours away, because you can't send every palpable lump to the center. So this is a really different way of thinking about implementation, and I think we're going to be doing more and more of this in global health, this type of approach. Ultimately, what they're developing is a model that can be scaled up at a national level, and I think this is going to be very helpful for countries that cannot afford mammographic screening and need to be thinking about more basic interventions. So this is a nurse midwife. She's providing education to the public. You also have to train clinicians because if they've never seen an early stage cancer, they may not recognize it. You know, it's not hard to imagine going to sub-Saharan Africa and someone saying, well, that's not breast cancer, it's not ulcerated, because they've never identified the small palpable lumps as something you had to work up. And you need educational materials. How do we do this? The Department of Global Health has amazing resources that they have developed in this way, and we're trying to tap into DGH in helping us. But why do we do this in Peru? Peru has an electronic medical record system. So every time someone is seen in one of those health posts, a form is filled out, and it gets entered into the record. This is how we can follow patients over time. So doing studies in places that have this type of data collection is a fundamental concept. Colombia is an upper middle income country. They had approached us back in 2006 because they were trying to talk their insurers into doing screening mammography. And what we did with them was a cluster randomized trial. This was based upon the same framework as the Shanghai trial. So this is an intervention trial, but the intervention is not on the women. The intervention is on the system. So the clinics were randomized, subcategorized by insurance group. In the control arm, women were consented and followed. In the intervention group, the hospitals and the staff were trained on early detection techniques with mammography, what do we do, quality standards, all of this. And what happened was, only about 17% of the women in the control group were actually undergoing a mammogram in this identified group of women 50 to 74, even though the ministry had said you're supposed to do this. So what did we see in this randomized trial? Well, we found more cancers in the clinics where the training was done, fewer cancers at later stage in the control group, and then at year 2 it reversed. So this was working in terms of finding the cancers. And interestingly, the groups that had more early stage cancers more had breast conservation therapy, whereas those that it didn't. So for my community, the surgical community, this is a great argument about why it is that you should be doing this early stage detection. You're going to get more breast conservation therapy. This is now out in the International Journal of Cancer. But you have to think more broadly than what we've said. You have to think about what are those concepts that the people believe. This was a study that was led by a Harvard radiologist working with our group, in which they surveyed the attitudes of women from Gaza, both in country and out of country. And when they asked the question, what do you think about early detection? Well, 90% said, yeah, I would have a mammogram if I felt something wrong in my breast, and a similar number thought that early detection was sensible. But if you said, if you don't feel anything wrong in your breast, would you then be willing to have a mammogram? Well, now you're down to 25 to 50%. And you have to realize that our system is also a belief system. So we tell women, you feel fine, but we want you to come on in. We're going to put your breast and squeeze it between 2 cold plates, and then we're going to get a picture, and then we're going to tell you there's something wrong. And then we're going to cut on it. We're going to change the shape and appearance of your breast. We're then going to give you a bunch of drugs, and your hair's going to fall out. And then we're going to burn you with radiation. But great news, at the end of this, you're going to be better. It's not hard to understand why someone, what are you talking about? I feel fine. So we all have our systems of the way that we believe. And so in a really comprehensive way of looking at this, instead of just focusing on the right side, which is what we tend to do, early detection, diagnosis, and treatment, you have to realize that there is a public side to this. So you have to produce survivors because they're the ones that organize and communicate, and they're the ones that promote awareness. It's not just listening to your doctor, it's the community. And thinking holistically is fundamental. So finally, I'm going to talk about what are we going to do with this? How are we going to try to move forward? The UN recognized way back in 1966, they identified healthcare as a right. But what they said, and this was very carefully selected language, everyone has the right to the highest attainable standard of care. Recognizing attainable is going to vary a lot. If you look at the distribution of total national health expenditure per capita, how much do you spend per person per year on health care? Well, we spend more than $4,000 in our part of the world, and we're having conversations about whether we're doing that well. But in low-income countries, it's $22. So clearly you have to adapt in any of the diseases that we're trying to treat. There are going to be some cancers where prevention is a strategy. There are going to be others where screening is going to help. We can compare outcomes with mortality in high income and low income. And ultimately, this is a publication that Andre Obawe, who used to be with us and is now at WHO, that we want to take different approaches based upon disease. It really makes sense in breast cancer to focus on early detection and treatment. When you talk about lung cancer, prevention is clearly the best strategy. And being able to identify this, particularly to public health people that may not understand the biology of disease, this is relevant. BCI 2.5, our goal is to improve outcome, and we're really at a ripe time for this. The United Nations held a very important forum in September of 2011. Prior to this time, what way WHO had looked at things is, we're going to talk about infectious disease. We don't really want to talk about that cancer stuff. And what they did was, they said, you need to now focus on non-communicable diseases. And the big four are heart disease, lung disease, diabetes, and cancer. And they shifted WHO's responsibility to say, you got to start thinking this through. I will tell you, cancer is still kind of the ugly stepchild of those four, and we're continuing to work on it, but it has created an opportunity that we did not have before. WHO created a global action plan with these voluntary targets, and one of them was a 25% reduction in risk of premature mortality from those big four. We use this as the basis for BCI 2.5. So our goal, it's a global campaign to reduce disparities in breast cancer outcomes for 2.5 million women between now and 2025. And we think this is aspirational, but potentially achievable, and that's why we're doing this work. We're coordinating between our groups in Seattle and international organizations. UICC in Geneva is the fiscal agent for our group, and it's a broad collaboration among organizations of like mind about how is it that we're going to address these outcomes. Our strategies are to raise awareness and build relationships. I've started to think, it may be education is the most important tool. It might be more important than any of the drugs or because if the women don't know and they don't participate, it doesn't matter what we have at the Cancer Center. Creating regional collaborations, doing analysis, principles of implementation science. What do you have so you can identify what you need? Performing situation analyses, country frameworks. How do we think this through? So we're holding a series of meetings that will address this and providing technical assistance in areas that are relevant. We're developing a library of decision-making tools following WHO's framework. So these knowledge summaries there's a total of 17 of them when we're finished. And the idea is that this will help us communicate with policymakers. So on the left is what you would need to know on the clinical side. On the right are what do the policymakers need to know? Why are we talking about this? Why should I be advocating for this versus that? Because most policymakers are not knowledgeable about medicine. What are we coming up with? We just launched our website. We're launching a breast cancer map on International Women's Day on the 8th. We're teaching, Julie Graylow and I and others from our group here is going to be teaching a course in Ghana. 4 sub-Saharan African countries are going to be represented, and we're going to be talking about team organization. How do you do this multidisciplinary care? And we're working with PAHO in Latin America for the Caribbean, for Central America and South America. Ultimately, what we're trying to do is develop models. The only way this is going to work is by building capacity in country. We might be able to help catalyze or facilitate that. That's our goal. So, in summary, breast cancer is the most common cancer around the world. It's the most likely reason a woman would die of cancer. It's a problem that has to be addressed. Improvement in breast cancer outcomes seen in high-income countries, these have not been mirrored yet in low- and middle-income countries, and even in some high-income countries. There are opportunities. Breast cancer incidence in the U.S. and other high-income countries peaked with use of screening mammography. The countries with improving breast cancer mortality, they linked the screening with the multimodality therapy, thinking systematically. Mammography is not affordable in most low- and middle-income countries, nor is it the best tool. Our focus on this is not the right question for the globe. CBE is necessary. It facilitates detection. It's a key part of the tool. We have to be thinking along these lines. And that resource stratified framework is a really useful tool for deciding how do we build. We often get criticized. Oh, you're certifying substandard care is okay. No, we're not. If you have the tools, use them. What we're saying is you build a foundation before you get up to the penthouse, and that we can provide that through resource stratification. But ultimately, it's going to be a collaboration among the clinical, public health sciences, and policymaking communities. That's how we're going to be able to do this. We have to think outside of our cancer centers in order to do this. So this is a really inadequate list of our collaborators from BHGI over the year. We're over 300 different specialists from around the world that participated. And that's where we're trying to go from here. Thank you very much for your attention, and I'd be happy to take questions.